without any further ado, I really look forward to presenting Dr. Anna Paholiouk, and I think you'll really enjoy her presentation, and we look forward to it. Thanks, Anna.
Thank you so much. Hello, everyone. Thank you, Dr. Presner and the Academy for this opportunity. Can you see it like that?
Yep, perfect.
Wonderful. Okay.
Thank you.
So more than 90% of my practice is focused on restoring posterior dentition. And today I would like to share with you some of my clinical cases and how I try to recreate nature's design applying biomimetic principles. Okay, I would like to start with things that I consider not negotiable in my practice. And magnification is the first one, because you truly can't treat what you can see. I practice with 8.5 magnification loops on a daily basis. Sometimes I go to 10x. And even then, it feels that it's not enough, especially when I work on a cracked tooth or I want to refine a margin. So I'm trying to convince myself that I'm ready for the next step, which is a microscope. Okay, rubber dam. Rubber dam isolation can be challenging, in certain cases especially. It's a skill, but if we can't isolate, we can't restore predictably. Because adhesive dentistry is chemistry. And chemistry requires a perfectly clean and controlled environment. So rubber dam offers exactly that. Caries detection dye is my visual map to achieve a peripheral seal zone, reliable peripheral seal zone. And this area must be absolutely clean from infected and affected dentin. Air abrasion is a must step for me because I'm using self-etch adhesives, so that's how I take care of the smear layer. And gold standard adhesives. Well, our true gold standard is the DEJ. In 2000, Urabi measured tensile cohesive strength of DEJ to be around 51 megapascal. And we use this as a benchmark, so to say, when we test our adhesives. So because Optibonifella and Clarifella most consistently approach it in the long-term performance, we call them a gold standard adhesives. So here we have a tooth. I removed existing restoration, applied caries detection dye, and what's next? Should I remove everything stained red and pink? I'm going to do a selective caries removal using 3x5 rule. It will help us to avoid pulpal exposures. So this rule states that we should not extend our preparation more than 3 millimeters axially, measuring from the contact of adjacent tooth, and more than 5 millimeters pulpally, measuring from occlusal surface of the tooth we are working on. The goal is to establish 2 to 3 millimeter wide circumferential area of sound enamel, DEJ, and dentin, and when we call it the peripheral seal zone. So when this area is clean, it becomes highly bondable. So we can achieve a good biomimetic bond strength, which will set the stage for a predictable long-term success. Hey, our first case, fun stuff. Okay. So this patient came in saying that he sees, when he brushes, he sees that one of his tooth has something dark and he's not sure if it's just a stain or decay. So he wants to know if there is anything that needs to be done. We're talking about tooth number 30, and when we test the pulp is vital. Okay, so the photo on the top that you see, that's how clinically the tooth presented on a clinical evaluation. Radiographically, there was no interproximal decay, so I know that those little white spots on the marginal ridges, just demineralization. We're going to avoid touching it. We want to take care of only what's needed. And when we do structural analysis, I see that, okay, yes, there is a failing occlusal composite. Yes, isthmus width is more than 2 millimeters, but nothing really crazy that stands out. So there was also little decay on the buccal pit. But again, as I said, I'm looking at this, I'm like, okay, OBL filling, not a big deal. So as soon as I remove that composite and applied caries detection dye, everything just highlighted red. And I'm like, whoa, okay. So the photo on the bottom that you see is actually probably like my 5th application of caries detection dye. And at that point, I know that this cusp is way less than 2 millimeters. So I'm taking this photo and I know I have to onlay it. On the top, you see that I did establish peripheral seal zone. I did not include the buccal pit in my outline. You know, I like doing things like this just to save a little sliver of enamel. So I restored it with a composite separately. And I was very happy that even though that distal marginal ridge has a pretty big undercut, I still could save it. On the bottom, you see that the tooth is already sealed. To do an immediate dentin seal with a resin coat, I used APX restorative composite to block undercuts. And here you see on a silicone model, me freehanding the composite onlay, and on the printed model, trying on. Okay, case number 3. Patient says that she also would like to change all her silver fillings, and I'm going to show you the quadrant. It's teeth number 13, 14, and 15. All teeth are symptomatic and pulps are vital. So here's this teeth. We're going to talk about tooth number 14 because it's obviously the most structurally compromised tooth. It has peripheral rim fractures on the distal marginal ridge, oblique ridge, and the distal palatal cusp is also not doing great. So I'm just going to tell you that number 13 got a MOD composite and 15 got a occlusal composite. So number 14, some MO amalgam with marginal breakdown, and when I removed it, I actually found some oblique fractures as well, so I had to onlay those buccal cusps. But the palatal cusp was nice and robust, so we could preserve it, so that was a good news.